In this section, we are going to discuss on the white blood cells. But the problem with the white blood cells is these cells also form the immune system. That is where the problem is. Usually the books that discuss on the white blood cells usually discuss immune system as a separate entity. But the real thing is that these cells don't only have disorders. At the same time, these cells also contribute a lot of things to the immune system, so that have to be discussed side by side. So that's why I did some hybrid kind of a thing, which is very easy to understand, so that I am going to discuss the immune system as well as the white blood cells side by side in the same way, so that it will be very easy for you to understand. So anyway, whenever you think about the white blood cells, there are typically two lineages of white blood cells you have. One is coming from the myeloid lineage, and second one is coming from the lymphoid lineage. You know, the lymphoid lineage gives rise to only lymphocytes, typically the T and the B lymphocytes, and many other cells are also there which are supposed to come from the lymphoid origin, but we don't have sufficient evidence for that. But typically the lymphoid lineage is going to give rise to the lymphocytes, which are nothing but the B and the T lymphocytes. And usually the B and the T lymphocytes are seen as cells of the adaptive immunity, But please do remember, there is considerable overlap between the cells of innate as well as adaptive immunity. But as a general overview, as a beginner, it is always better to oversimplify things so that you can understand this lymphocytes always goes towards adaptive immunity as a beginner. So the myeloid lineage cells typically give rise to two things. One is called the granulocytes, and second one you have something called the monocyte macrophage lineage. Monocytes are the ones in the tissues, they are going to become something called macrophages. But this monocytes, you have one special property. The monocytes and the macrophages, especially like AK, these monocytes also means they are macrophages, and they form something called a group of cells called antigen presenting cells, and they are the ones that form the bridge between the innate immunity and the adaptive immunity, the antigen presenting cells. Along with it, you have dendritic cells also that comes from again like innate as well as adaptive lineage, and you have dendritic cells that are of innate immunity and dendritic cells that are of adaptive immunity also. But in general, these macrophages or antigen presenting cells are the ones that forms the bridge between the innate immunity and the adaptive immunity. In general, if you ask me, these granulocytes are typically cells of innate immunity, usually not always, but these granulocytes are typically the cells of innate immunity. Whenever you ask what are the granulocytes, they generally go towards three cells. One is called PMN, that's a neutrophil granulocyte. Second one, it goes towards eosinophils, and third one you have something called a basophil. So neutrophils, eosinophils and the basophils are the typical granulocytes. Usually this monocyte doesn't have that much granulation, so generally they are not called as granulocyte, to be honest, but they are coming from the myeloid lineage. Myeloid lineage is the one that gives rise to these granulocytes as well as the monocyte macrophage cells, and the lymphoid lineage stem cell gives rise to the lymphocyte, that is the B lymphocyte and the T lymphocytes. Note that the myeloid lineage is also responsible for the formation of erythrocytes as well as the formation of platelets. That is called common myeloid lineage stem cell. So this is called as common myeloid progenitor. That is the one that is going to give rise to the RBCs, platelets, and all these things are also formed by the myeloid lineage cell only. But for this WBC related purpose, it's better to understand only granulocyte macrophage from the myeloid lineage and the lymphocytes from the lymphoid lineage. We'll forget about the other things as of now. So these are the things that are very, very important. So the moment you discuss about the immune system, before going into the cells per se, let us see what are the differences between the innate immunity and the adaptive immunity. Innate immunity and adaptive immunity. Innate immunity is nothing but these are the first line of defense, as is usually described in majority of the textbooks. These are going to be the first line of defense, and adaptive immunity are generally called as first line, second line or third line of defense, not the first line. And typically innate immunity is non-specific, and they are going to recognize, the same cell can recognize multiple different pathogens. That's what the meaning is. It's not about they recognize many pathogens. Even adaptive immunity can recognize many different pathogens, antigenic combinations. But what I'm trying to tell is the same particular cell can identify multiple different antigenic combinations and cells. And the adaptive immunity tends to be very highly specific, which means a particular cell can identify only a particular antigen. They can identify many antigens as a group of cells, but a particular cell can identify only a very particular antigenic combination. So which means they are highly specific, one-on-one combination. But innate immunity, one-on-many combination, like many things they can identify, can be identified by a single particular cell. And if you ask me, innate immunity, they are scattered throughout the body, everywhere. But they are located only in specific sites, the adaptive immunity. Like for example, you have lymphoid organs, primary and secondary lymphoid organs. Only in these areas your adaptive immunity is located, but innate immunity is scattered throughout the body in all the areas. So again, innate immunity has no immunological memory, but whereas adaptive immunity, you have memory, because they form memory B cells, memory T cells and all these things. So they do have something called immunological memory. They identify the antigen which has been recognized in the past, and when next time the antigen comes, they can surely induce a more powerful response. That is what we refer to something called immunological memory. Then innate immunity is the one that acts extremely early, whereas adaptive immunity is the one that comes a bit late to the party. So all these are basic differences between the innate and the adaptive immune system. Let us go to the cells of the innate immunity now. We are not going to discuss much on the adaptive immunity. Later on, we'll discuss on the adaptive immunity as it comes late. But as of now, we are going to discuss on the innate immunity basics. So what are the basics of the innate immunity? The first thing, whenever you think about the innate immunity, the first thing they will ask is about the physical, chemical and the biological barriers that form the innate immunity. Apart from the cells, there are certain things called physical, chemical and biological barriers of the innate immunity. So what are the physical, chemical and biological barriers that contribute to the innate immunity? So the first one is the skin and the mucosa. Skin and the mucosa. So skin and the mucosa, basically these are walls, isn't it? The skin is a wall, mucous membranes is a wall. So these are the basic defense. And the skin and the mucosal membranes typically have lot of tight junctions between the epithelial cells that prevent any movement of the pathogens into the body. They prevent the access of the pathogens into the body by the presence of tight junctions. That is what you have to understand. And they also contains lot of ciliary functions, typically in the respiratory tract. That is what we refer to as something called ciliary escalator activity, so that whenever some antigen comes, by ciliary action they wipe off the antigens out of the body. So they push the antigens literally by fan-like action. So that's what you're going to see. And acid pH, that is low pH. Typically, as you see this low pH, that is acidity in two areas that prevents the organism from colonizing. One is the stomach, that is because of the hydrochloric acid, and second one is the vaginal area where you have low pH because of the hormonal activity. So in all these conditions, this is going to act as a barrier. And normal flora in many places, normal flora, which is typically we are going to call it as commensal organisms. So these are also going to form a lot of barrier-like system, because these provide a lot of competition for the pathogenic bacteria, which means pathogenic bacteria and pathogenic organisms can't survive in the presence of excessive commensal organism, because they also compete for the nutrition in the same area. So this commensal is also very important, because one of the classic diseases caused by alteration of the commensals is Clostridium difficile. Not only that, many of the diseases has proven to have some relationship between the disruption of the commensal organism. So that is why now this is gaining a lot of importance. But do understand that best example for this is C. diff colitis, Clostridium difficile colitis or pseudomembranous colitis. That's a very important example of a disruption of the commensal organisms causing a disease. And you have a lot of chemical barriers. So chemical barriers, in the sense, the first one is the mucus chemical barrier. Yeah, in the mucous membranes you have mucus. This mucus may contain antibacterial compounds like lysozyme. They can contain lactoferrin. Then they can even contain immunoglobulins, especially immunoglobulin A on the mucous membranes. Do you know one thing? Immunoglobulin A is the most abundant immunoglobulin in the entire body. In the blood, immunoglobulin G is what is predominant, but in the body, if you take IgA is the predominant. The maximum amount of most abundant immunoglobulin in the body, if somebody asks you, it is IgA. Abundant immunoglobulin in the blood, if they ask you, it's IgA. I'm not arguing with that, but in the body, it's always IgA because you have the surface area of the mucosal tract is too much, and the entire mucosal area from mouth to anus and throughout the respiratory system, it is sprinkled with IgA. So much of IgA is present in the body, the most abundant immunoglobulin in the body. And mucus, this lactoferrin. And what is the function of this lactoferrin? Lactoferrin, if you ask me, the major function is they bind with iron and prevent the iron from getting available for the bacterium. So that is how lactoferrin is helpful. And lysozyme is formed by many areas. It's seen in tears also. It can be secreted by neutrophils, other granulocytes as well as macrophages. And this is a very non-specific antibacterial agent, but still it's a very important thing that is present in the mucus. And a lot of biological barriers are there. Biological barriers, if they ask you, very important is the cough, sneezing and all these things act as physical as well as biological barriers, where coughing and sneezing may easily extrude the organisms out of the system. Apart from that, in the chemical barriers, I didn't tell you about this thing. So you have a lot of cytotoxic molecules and proteins that are released in the local area by exocytosis. Like for example, you have something called major basic protein, that's called MBP, which is usually coming from the eosinophils and all these things. And second thing, you have a lot of other things like defensins, which is again coming under innate immunity. Then you have something called acid hydrolases, and you have something called RNases, and a lot of free radicals are also generated in the local area. So all these are some chemical barriers to the to prevent the access into the body from the pathogenic microorganisms. So these are some of the barriers that you have to know. So physical, chemical and biological barriers. The second thing, if they ask you, the second thing is the cells. Cells is very important again to understand about the barriers because they form a very important innate immune barrier. The most important cells, as I told you, that contribute to the innate immune system is granulocytes, and second one is the macrophages, and you can also add the dendritic cells to it because both contribute, as I told you, both contribute to the antigen presenting cells, but generally antigen presenting cells form a bridge rather than the true innate immune system, but they can be considered as innate immune system, but in general they form a bridge between the innate and the adaptive immunity because they present the antigen to the adaptive immune system as well. As I told you, the granulocytes are nothing but neutrophils, eosinophils and the basophils. And one more thing I didn't tell you, this basophils, when it moves into the tissue, we are going to call it as mast cells because mast cells also can be, because the same reason, can be considered as the innate immune cell. Then next thing, if you ask me, what are the definitions of leukocytosis and leukopenia? For example, what is a normal WBC count? Normal WBC count, if somebody asks you, typical value which you are learning from the first year of MBBS, that is 4,000 to 11,000 per microliter or per cubic millimeter, whatever you can tell. That is what is the normal WBC count in the blood. If it's going to be less than 4,000, some books will give you less than 4,500, but that's also right. We are going to call it as something called a leukopenia. And when it is going to be more than 11,000, and some books will give you 10,000 also, but that's fine. So we are going to call it as something called leukocytosis. Clear, there are a lot of causes of leukopenia and leukocytosis. I'm not going to discuss that primitive things, but anyways, there is one entity, you have something called leukemioid reaction. There is one entity, you have something called leukemioid reaction. So what do you mean by leukemioid reaction? Leukemioid reaction is nothing but something called reactive leukocytosis. Leukemioid reaction is something called reactive leukocytosis. What is the speciality of this leukemioid reaction is? Leukemioid reaction will have all subdivisions of the cells. There will be increased proliferation of, in the peripheral smear if you take and see, there will be increased proliferation of all myeloid elements. All myeloid elements. It is not only the particular immature cells. There will be combination of mature cells, there will be immature, a little bit left shift will be there, where immature cells will be increased in number, but it's not only the immature cells that are present, there will be a lot of mature as well as immature cells. That is the difference between the leukemia. Leukemia will have completely immature cells that is distributed throughout the body and the blood, but whereas in leukemia reaction, all myeloid lineage components, including eosinophils, your basophils, then even monocytes, neutrophils, everything will be sprinkled throughout the system. So proliferation of all myeloid elements, not a particular myeloid element. Very, very important. Particular myeloid lineage cell, and especially if it's immature, if it's increased in number, it more goes towards the leukemia. But all the myeloid elements increased in number and expanded, that is what we refer to as a leukemia reaction. And a very important thing to understand leukemia reaction, how will you, the most important point in leukemia reaction is they're going to have a increased lab score, that is called leukocyte alkaline phosphatase score. This is a very important point because one of the important DD for a leukemia reaction is CML. Even though in CML you will have the myeloid elements more immature forms rather than mature forms, but very important, sometimes it can be very difficult to differentiate from CML because, in peripheral smear I'm talking about, because CML means there will be Philadelphia chromosome positive, which we'll discuss in detail, that is BCR-ABL translocation. But apart from that, CML in peripheral smear may sometimes look like a leukemia reaction. So you have to understand that CML will have reduced lab score. As far as the entrance exam is concerned, whenever they ask you about conditions which has low lab score, you have to first thing tell is CML, because it's the thing that in the past very useful for differentiating leukemia reaction from chronic myeloid leukemia. At the same time, another important thing that has reduced lab score is paroxysmal nocturnal hemoglobinuria, that is PNH, which you have discussed already. But remember, CML is a very important DD for leukemia reaction. Leukemia reaction, you will definitely have an increased lab score. What are the reasons for leukemia reaction? Very important reason is the sepsis. Sepsis or any endotoxic shock can result in leukemia reaction in expansion of the number of cells more than what is required. And second very common area where we see is the steroid use. Very, very important. This is, we commonly see in the ICUs where we start with steroids, patient enters leukemia reaction and a lot of cells will be there after using the steroids, and it won't come, and the intensivist thinking that it is due to infection and they'll be changing antibiotic after antibiotic, not knowing that the patient is already getting steroids. So steroids is a very important cause of leukemia reaction where the counts may increase and there will be more of left shift also, and all the myeloid lineages may be increased in number and can be expanded. So it can also be associated with certain tumors, especially I'm not talking about the hematological tumors, I'm talking about the solid organ tumors like lung cancer or a kidney cancer. So that is the reason why sometimes these tumors, because of they have excessive myeloid lineage cells, they might even mimic a leukemia also, hematopoietic malignancy also. So these are also very important. The solid organ tumors, especially the lung and the kidney, can induce a leukemia reaction. So the entire idea is to understand the leukemia reaction in this particular section. So that's why it is really, really important. So then coming on to the key cells, that is the granulocytes. So our basic understanding in this particular video will be on the granulocytes. Key understanding is in the granulocytes. So I told you how the granulocytes start is, first of all, how it starts, origins is from the hematopoietic stem cell. Everyone knows that. This is otherwise referred to as something called a pluripotent or uncommitted hematopoietic stem cell. This can either commit into a lymphoid lineage or can commit into a myeloid lineage. So let us assume it commits into the myeloid lineage and becomes something called CFU-GEMM. This is what we refer to as something called a common myeloid progenitor, or simply you can even call it as a myeloid stem cell or a committed stem cell. This is the myeloid stem cell, CFU-GEMM. Then it can give rise to many different divisions depending on what kind of growth factors that are stimulating the particular this common myeloid progenitor. To understand this, because it's a very complicated process, to understand this, I have a very simplified diagram for you in the form of this, where you can see here. So you have something called initially a pluripotent hematopoietic stem cell. the survival of this pluripotent hematopoietic stem cell is dependent on two important growth factors. One is called the stem cell factor, which we have discussed already in the basics of hematology, and second one you have something called FLT3 ligand. Again, very, very important. These two are very, very important for survival of stem cells. Survival of hematopoietic stem cell, that is pluripotent hematopoietic stem cell, very important. SCF and this thing. At the same time, you have a lot of overlapping growth factors are there. For example, IL3, why it's shaded everywhere, this IL3 in this diagram, is because IL3 is helpful for survival of pluripotent hematopoietic stem cell. At the same time, it is also helpful for survival of every other lineage in the myeloid area, like your common myeloid progenitor, megakaryocyte progenitor, erythroblastic progenitor, then granulocyte macrophage progenitor, then you have eosinophilic progenitor, granulocytic progenitor, then monocytic progenitor. For all these three things to survive, your IL3 may act as a booster. So IL3 is one thing that has extremely overlapping actions, so including the stem cell. But one more thing that also has a lot of overlapping actions, if you ask me, that is the GM-CSF. This GM-CSF is not important for the stem cell survival, but it is important for all the other lineages as well. All the other lineages also need your GM-CSF. To an extent, GM-CSF helps in the myeloid lineage cells, but not for the stem cells. For the myeloid lineage cells, GM-CSF again is very important and has a lot of overlapping action. So there are two things for the myeloid lineage that are important, that is IL3 and GM-CSF. I'll write separately IL3 and GM-CSF. Both are important for survival of the myeloid lineage cells. These are a lot of having overlapping actions. Remember, IL3 is important for survival of hematopoietic stem cell as well as myeloid cells, whatever myeloid lineage you get, and GM-CSF is not important for hematopoietic stem cell and it's important only for myeloid lineage stem cell. Remember, stem cell factor and FLT3 ligand is not important for myeloid lineage at all, it's only important for survival of the stem cell. So this is very, very simple diagram to understand. And once you know this is committed, now you can see this is a committed stem cell, that is CFU-GEMM, that is called a common myeloid progenitor. This is called a common myeloid progenitor. From this common myeloid progenitor, you can get another colony of cells that's called CFU-GME0, where you have this can give rise to granulocyte, this can give rise to monocyte, and this can give rise to eosinophil also. So that's why it's called CFU-GME0, which again divides into either CFU-GM, that is called a granulocyte monocyte or a granulocyte macrophage progenitor, or a CFU eosinophilic progenitor, or a colony forming unit eosinophil. It can give rise to any one of them. So once it splits into any one of them, the further differentiation depends on what type of growth factor you are getting. For example, if the CFU-GM is stimulated by GCSF, it's going to enter the granulocyte colony forming unit. If CFU-GM is stimulated by the MCSF, it's going to enter the monocyte lineage. If this CFU eosinophil, once it's formed, it's stimulated by IL-5, interleukin 5, it's going to become eosinophils. Similarly, for example, if you see, if CFU, like the common myeloid progenitor becomes a megakaryocyte, if thrombopoietin, this TPO is the one that is stimulating, it becomes blast forming unit megakaryocyte and it's going to differentiate into platelets. Similarly, if it's stimulated by erythropoietin, it's going to differentiate into erythroid lineage. So once, like I told you, this GM-CSF and IL-3 are important for survival of the all the myeloid cells, but in that particularly, once, like the myeloid cells are surviving, depending on what is stimulated. For example, if it's GCSF, you are going to get granulocyte. If it's MCSF, you're going to get monocyte macrophage, like type of cells. If it's IL-5, you are going to get eosinophils. Similarly, if it's TPO, thrombopoietin, you are going to get platelets, and if it's erythropoietin, you are going to get RBCs. Depending on what growth factor is acting on what type of that myeloid lineage cell, depending on the differentiation and activation of that particular lineage cells will happen. So this is a very, very important point to understand. So there are two overlapping growth factors, that is interleukin 3 and granulocyte macrophage colony stimulating factor, that is GM-CSF. Apart from that, lineage specific growth factors are also there, which are nothing but G-CSF, M-CSF, IL-5, thrombopoietin and erythropoietin. But in this particular thing, we have not discussed on basophils. We have not discussed on basophils. Where are the basophils gone? Because basophils are generally a controversy. Basophils in general are a big controversy because we really don't know where the basophils are originating from. Certain sources do tell that the basophils are actually originating from the common myeloid progenitor itself. So certain sources are telling the basophils are originating from the common myeloid progenitor itself, but certain sources, certain research articles are telling that the basophils are originating from granulocyte macrophage colony forming unit, that is CFU-GM. So does the basophils originate from here? But we have evidences for both. We have controversies for both also, but we don't know exactly where it's originating from. Either basophils can originate as a separate colony from the myeloid progenitor cell itself, like erythroid, megakaryocyte and GME0, like that you can have a separate basophil colony forming unit as well. At the same time, basophils can originate from your granulocyte macrophage lineage also. But the evidence tells that the basophils are originating from the common. That's where the evidence is more towards, but still it's not conclusive, but still that is where the evidence is more towards. So if somebody asks me what you'll go for, I'll go for the basophils originate from the CFU-GEMM, that is common myeloid progenitor, that is granulocyte, eosinophil, monocyte, macrophage system. So this is where it originates from. That's a common myeloid progenitor. Then these are the important things. At the same time, how they grow, for example, from CFU-GM, for example, whenever you have a colony forming unit, granulocyte macrophage system, so this is going to become a myeloblast. This is going to become a myeloblast if it's going to form, if it's stimulated by a G-CSF. If it's stimulated by a G-CSF, it's going to become a myeloblast. This myeloblast is going to become a neutrophilic promyelocyte, and this neutrophilic promyelocyte is going to become a neutrophilic myelocyte, and this neutrophilic myelocyte is going to become a metamyelocyte. This metamyelocyte is going to become something called stab forms or a little immature forms called band forms, and finally they are going to become something called a mature neutrophil. So this is the journey of a neutrophil. This is how it comes, but the starting point from CFU-GM is this G-CSF. That is the one that makes the CFU-GM, that colony forming unit, granulocyte macrophage cell, to differentiate into the neutrophil lineage. But there are 2 points that are important. So the moment I call neutrophilic promyelocyte, this neutrophilic promyelocyte is the area where you have something called primary granules or primary azurophilic granules. These are the time where the primary granules appear in the neutrophil, and similarly this neutrophilic myelocyte is the time where your secondary granules of the neutrophil, we are going to discuss what are primary and secondary granules in some time, trust me, but this secondary granules appear usually in the neutrophilic myelocyte stage. The primary granules appear in the neutrophilic promyelocyte stage. Similarly, if the same CFU-GM is stimulated by the M-CSF, let us see what will happen. If it's stimulated by the M-CSF, then they will result in formation of something called monoblast. This monoblast will become something called promonocytes. This promonocytes will become something called monocytes, and that is in the blood. And these monocytes will enter the tissues and where they will be called as macrophages, otherwise called as tissue macrophages, and they will be either participating in a war, or they will reside for some time and they will die when their turnover time is over. So this is what we call macrophages once it enters the tissues. Similarly, you have something called CFU GMM, which can become colony forming unit basophil. Still, I told you there's a controversy whether we don't know it's originating from CFU GM or not, colony forming unit GM or not, but I told you I believe the research article, because it's published in NEJM already, there is a lot of evidence for basophils originating from CFU GMM. That's why. So you have CFU basophils, which can form something called, and what is the, I didn't tell you the, growth factor that makes the, myeloid progenitor cell or the CFU GM cell to commit towards the basophilic lineage. Probably what could be the reason? Probably it is thought that probably something called a nerve growth factor is there, NGF. I mean, again, we are very inconclusive on that, but that could be the one that might push the lineage towards the basophilic differentiation. But anyway, fine. So you have something called a basophilic promyelocyte, then you have a basophilic myelocyte, then you have a basophilic metamyelocyte. Similarly, you have like a neutrophil, you have a stab and a band forms also, and you have mature basophils. Finally, you have mature basophils, and these mature basophils, if they enter tissues, we are going to call it as mast cells. Once they enter the tissues, they will be called as something called mast cells. As simple as that. So this is how you are going to get a lineage. And similarly, you have eosinophils also. You have something called CFU GME0. From this particular colony, if the IL-5 is the major stimulating cytokine from the CFU GME0, you are going to get CFU eosinophilic colony, that's colony forming unit eosinophils. Then you are going to get eosinophilic promyelocyte. Similarly, you are going to get eosinophilic myelocyte, and you are going to have eosinophilic metamyelocyte, and finally you will get stab or band forms or little immature forms of eosinophils, and finally you are going to get mature eosinophils. So these are the basic ideas about how you get from different lineages. Remember, if this interleukin 5 is not there, suppose if this interleukin 5 is not there, then this CFU GME0 is going to become CFU GM if there is no interleukin 5. If there is interleukin 5, that's going to get differentiated into your CFU E0. But if interleukin 5 is not there, then it's going to become CFU GM. From there, if GCSF is there and acting on that particular cell, it will enter the granulocyte, that is neutrophil lineage. Or if there is MCSF, it's going to enter your macrophage, monocyte macrophage lineage. As simple as that. That's all. So this is what is going to happen. Similarly, that's what we have discussed in this particular diagram also. For example, from this CFU GMM, if you have this TPO or erythropoietin, they are going to go into platelet or erythroid lineage. But if you don't have the TPO or if you don't have that erythropoietin, this is going to differentiate into CFU GME0 only. Depending on IL-5 ability, if IL-5 is there, they will go into the eosinophilic lineage. If IL-5 is not there, they are going to differentiate into CFU GM. Similarly, if GCSF is there, they will enter the neutrophilic granulocyte neutrophilic lineage. If MCSF is there, then they are going to differentiate into monocyte macrophage lineage. As simple as that. This is what we call lineage specific differentiation. So the growth factors are also very important. Final thing that I want to tell in a nutshell, IL-3 GM-CSF is important for the entire myeloid lineage. If TPO is available, they will differentiate in the common myeloid progenitor will differentiate into megakaryocyte lineage. If erythropoietin is available, the common myeloid progenitor will differentiate into erythroid lineage. If both are not available, they are going to differentiate into GME0. That's a common stem cell for both committed stem cell for granulocyte, macrophage as well as eosinophil. If IL-5 is available, they'll go towards eosinophil. IL-5 is not available, they'll go towards granulocyte, macrophage area. So if GCSF is there, the CFU GM cell will differentiate into neutrophil. If MCSF is there, then it's going to differentiate into monocyte macrophage series. But basophils, I told you it's controversial. Typically it comes from the common myeloid progenitor, but the thing that probably differentiates into the makes the common myeloid progenitor differentiate into basophilic lineage is the maybe query nerve growth factor. That's it. But apart from that, we don't have much of growth factors to understand. So these are the very important growth factors that you should know for your exams. So once you know about these growth factors, it's very important to know about some of the features of the individual cells, which is very important. So the first individual cell that we are going to discuss is on the neutrophils, which is a very important component of a granulocyte. Neutrophils. Majority of them, most common type of cell in the blood is neutrophils only, and the most common granulocyte in the blood is also neutrophil only. That's why it's very important. Here, this is a typical thing that you see, because neutrophil has multiple lobes, you know that. And let us assume some basic properties. I will tell you whenever I discuss a cell, I will tell you the basic properties of the cell here. Then I will tell you the function of the cells in this area. Then finally I will tell you where the cells will increase and where the cells will decrease. What are the things that will affect the cells? So let us see first of the basics. Basics in the differential count, if you ask me, neutrophils contribute to 50 to 65% of the differential count in the peripheral blood. And typically diameter is around 10 to 15 micrometer, but in general average in many textbooks it's given as 12 micrometer of diameter. And usually, mature neutrophils come from stab forms, or otherwise referred to as band forms, which give rise to mature neutrophils. And the maturation process takes place around 4 to 5 days. It's a very important number. So the stab forms or the band forms transform into mature neutrophils by around 4 to 5 days. And the mature neutrophils, once released from in the blood, they are going to stay in the blood for around 4 to 5 days, and again they are going to enter the circulation. In the circulation, they typically spend around 6 to 10 hours of time. 6 to 10 hours of time in the circulation. After that, they are going to enter the tissues, where in the tissues they are going to spend approximately 4 to 5 days. During this 4 to 5 days, they either die during a war, or once their lifespan is over after 4 to 5 days, they die by apoptosis. But anyway, either way, they die after spending 4 to 5 days in the tissues. So this is what is going to happen. And very important thing is, whenever you see a vessel, there are two pools of neutrophils are there. The first type of neutrophils are the ones, this is what we refer to as something called circulating pool of neutrophils. And the second pool of neutrophils are the neutrophils that are present on the sides. This is what we refer to as something called marginated pool of neutrophils. So this is what we refer to as something called marginated pool of neutrophils. So let us assume this is the marginated pool. So if somebody asks you what is the percentage of neutrophil that is present in the circulating pool and the marginated pool, answer is 50:50. That is 1:1 or 50% to 50%. The 50% of neutrophils in the vascular compartment are in the circulating pool, and 50% are in the marginated pool. But very important to know that the circulating pool of neutrophils is the one that is measured when you take the blood from the patient and see. This is the one that is generally measured, and the marginated pool cannot be measured. So this is a very important thing. Why? Because the moment when you give the patient with steroids, which means the marginated pool does not reflect the true neutrophil count, because it is not measured in the routine blood count that what you do. The marginated pool is something, it's not measured. So when you give steroids will detach this marginated pool of neutrophils from the marginated pool into the circulating pool, which means that is the reason why steroids can induce leukocytosis. Whenever they ask you steroids induce leukocytosis, means steroids are going to produce increased total count, and typically they are going to produce neutrophilia. Steroids are going to cause neutrophilia. That is also the same reason why in Cushing's disease you are going to get neutrophilia. And in Addison's you will get neutropenia, because in steroid deficiency, marginated pool will expand, whereas circulating pool will reduce. Whereas in steroid excess, like when you give exogenous steroids, or when you are going to give, when you are going to experience a Cushing syndrome, your marginated pool will enter the circulating pool, so you might result in a neutrophilia. So very important. So all these things. So these are the basics of the neutrophils, because you have to know in and out about the neutrophils. Second thing, let us discuss the function of the neutrophils. Function of the neutrophils, typically there are two functions. One, they can have something called intracellular killing, because killing is these are soldiers, isn't it? So the killing is their main process. So one is intracellular killing, and the second one, they are going to have something called extracellular killing. Extracellular killing. So how they are going to do intracellular killing? Intracellular killing means they are going to kill by phagocytosis. They are going to kill by phagocytosis, especially bacteria and fungi. They cannot ingest big organisms like parasites. Generally, they don't ingest like a lot of viruses also. But anyway, bacteria and fungi are the major agents for phagocytosis of neutrophils. So phagocytosis. Extracellular killing, this is a very important thing. They are going to do that by something called NET. That's called neutrophilic extracellular traps. Neutrophil extracellular traps. You have a lot of things that are coming up in traps. Even NETs has been even associated with SLE also. But anyway, so many things are coming here. What happens is either most often a dying neutrophil, or less commonly even a living neutrophil, can combine all the nuclear and the cytoplasmic components, and they release like a web-like or a mesh-like substances. Web-like or a mesh-like substances in the extracellular region, where an organism traveling in that area may get trapped in that mesh created by this neutrophil, which is either a good living neutrophil or a dying neutrophil. Anything can, very commonly a dying neutrophil is the one that is going to produce this mesh, and which is containing all the cytoplasmic as well as the nuclear chromatin components, and they form a web-like thing, a spider web-like thing, where the organism gets trapped. And this trapped organism, while passing through the area, when it is trapped, it can be phagocytosed by a nearby neutrophil, or this web itself contains a lot of dangerous and toxic enzymes, the cytoplasmic component of the neutrophils, that itself might kill the organism. So this kind of extracellular killing mechanism of the neutrophil is what we refer to as something called neutrophil extracellular traps. So intracellular killing is very, very simple. It's a well-known entity that neutrophils chase and swallow the organism. That is typically something called phagocytosis. And next thing, we have something called neutrophilia. That is whenever counts are increased, and whenever counts are decreased, they are called as neutropenia. Actually, I don't believe neutrophilia is that important. Neutropenia is really, really important, because neutropenia is a very, very dangerous entity. And we have a lot of things we are going to discuss in oncologic emergencies later on, but very important, this neutrophilia and neutropenia, especially the neutrophilia. Neutrophilia means whenever the absolute neutrophil count exceeds 7,500. So we call it as neutrophilia. Apart from that, plus or minus, if the DC count exceeds 75%, we can call it as neutrophilia, but this is not at all important. What is more important is the absolute neutrophil count exceeding 7,500. That is the typical definition of a neutrophilia. Similarly, when you call neutropenia, if the absolute neutrophil count is less than 1,500, so this is what we refer to as neutropenia. Suppose if it is in the range of 1,000 to 1,500, we are going to call it as a mild neutropenia. If it is in the range of 500 to 1,000, we are going to call it as moderate neutropenia. And whenever the count is less than 500, we can call it as a severe neutropenia. Very commonly, we encounter these kinds of severe neutropenia in patients who are taking cytotoxic drugs like methotrexate or chemotherapeutic agents. Very, very commonly, we have seen a lot of patients who come with fulminant sepsis and infections, don't even have a fever because they don't have sufficient neutrophil to even produce a febrile reaction. So febrile neutropenia, that is especially the severe neutropenia, is a very, very dangerous entity where we immediately start with a lot of empirical antibiotics and stop the chemotherapy drugs, whatever the patient is taking. Anyways, so this is what is going to happen. So tell me few causes, let us know some of the few causes of neutrophilia and neutropenia. Neutrophilia, typically the number one you're going to call it as infections. Very typically what infection? It's going to be bacterial infection. So whenever if it's associated with bacterial infection, you're going to get the neutrophils. If you ask the peripheral smear in the pathologist, they are going to give something called neutrophils are increased with toxic granulations. Plus or minus, they are also going to have something called Dole bodies, which we'll discuss in some time. So Dole bodies. All these things can be seen. And second thing, in any inflammatory condition that produces SARS. Typically even sepsis can produce SARS. Apart from that, you can get in burns, you can get in tissue necrosis. And whenever the patient is having MI, pulmonary embolism, or patient is having acute pancreatitis, lot of conditions. So anything that induces SARS can have neutrophilia. Similarly, number 3, patients who are taking some drugs. Very important 2 drugs for exam. One is steroids, easy, which can produce neutrophilia, because I told you the same principle. At the same time, patients who are taking GCSF, very important, very common. If you have ever used GCSF, you will understand it's a very commonality. After you give GCSF, neutrophil count usually rises and even go to the 20,000-30,000 range. So that is due to sudden, differentiation into the neutrophilic pathways from the common myeloid progenitor. So GCSF and beta agonists. Beta agonists not that important, but still it's okay to know. Then you have lithium, then probably cigarette smoking. All these things can result in neutrophilia. Then you have stress, that is due to release of endogenous catecholamines. Then you have stimulation of marrow or increased hematopoiesis. Overall, when you get increased hematopoiesis, is an iron deficiency anemia where RBC will not be there, but your neutrophilic lineage may be increased because of the block in one particular area. Other thing may be happening in iron deficiency anemia and in hemolytic anemia and in something called immune thrombocytopenic purpura ITP. You might have neutrophilia because it's a that is blocked, so you have alternate lineage that is synthesized more. Then in asplenia, whatever, it could be surgical or anatomical or functional, or it could be even congenital, whatever may be the cause, asplenia. Because a lot of blood cells are actually sequestered inside the neutrophils. Sequestered inside the spleen. When spleen is not there, the sequestered cells will come back to the circulation and it will look as it is, they are expanded. Then a lot of neoplasms, or it could be paraneoplastic syndromes. Neoplasms, typically myeloproliferative neoplasms like CML, or PNS, paraneoplastic syndromes, especially lung and gastrointestinal cancers, can produce neutrophilic response. Number 8, finally you have something called leukemioid reaction. Leukemioid reaction, as I already told you, the count usually will be more than 50,000 plus patient will have left shift. What do you mean by left shift? Left shift means production of more immature cells, but all the myeloid lineage will be expanded here. That's very important. So plus left shift, but it is not due to leukemia. And these patients will have increased lab score, which you've discussed already, unlike CML where they have low lab score. Okay, so these are some of the important causes of neutrophilia, but more than neutrophilia, the neutropenia is the one that is going to be more important. So what are the different causes of neutropenia? So if you ask me what are the different causes of neutropenia, the number one, let me talk about the congenital causes. Congenital causes, you have a lot of causes. One is called myelokathexis, which you are going to discuss in the disorders of the neutrophils in some time. Then you have something called Shwachman-Diamond syndrome. SDS is due to SBDS gene, which discussed in the last video, the marrow failure syndrome, where the predominantly SDS syndrome patients will have neutropenia as a major marrow failure entity. And the patients might have, in patients who have something called Chediak-Higashi syndrome, that's called CHF. Then you have something called WHIM syndrome. All these things we are going to discuss in the next section. Don't worry about it. And you have something called a Monomax syndrome. Then you have something called a Kostman syndrome. Then you have something called cyclic or ethnic neutropenia. Cyclic neutropenia, and separately you have ethnic neutropenia also, but that's not important. Cyclic neutropenia. Remember, in this we have already discussed on Shwachman-Diamond syndrome. Every other single syndrome will be discussed in the next section. Obviously, these are some congenital causes of neutropenia. Don't worry about that. And second thing, you have infections. Lot of infections. Typically, lot of viral infections can cause neutropenia, or even a lot of bacterial infections can cause neutropenia, or a lot of parasitic infections can cause neutropenia. So viral infections that can result in neutropenia is typically CMV, HIV and Epstein-Barr virus. Bacterial infections that can cause neutropenia are typically Brucella, certain rickettsial species, not always, but certain rickettsial species and TB can cause neutropenia, and parasitic infections like malaria can cause neutropenia. So these are some of the infections that can lead to neutropenia. And number 3, you can have nutritional, typically in B12 or folate deficiency and copper deficiency. So where because of defective nuclear maturation you might get not only anemia but also neutropenia or even pancytopenia in B12 and folate deficiency. Then you can get in chemotherapy drugs, chemotherapy plus other drugs. Very important is the chemotherapy. Lot of chemotherapy drugs can result in complete bone marrow failure and complete bone marrow suppression and neutropenia. Other drugs that you have to know apart from the chemotherapy drugs is clozapine can result in agranulocytosis. Very, very important drug for exam. Then you might get with anti-thyroid drugs, especially your methimazole and carbimazole. Again, a very, very important entity. Then you can get with trimethoprim sulfamethoxazole, that is cotrimoxazole, very important entity. Then you might get with colchicine, can induce agranulocytosis, again a very important entity. Then you can get with sulfasalazine, again very important entity. Then you can get with phenadoin, not so important, and you might get with NSAIDs, again not so important. So these are the things that can cause neutropenia and agranulocytosis. Very important for exams is clozapine, anti-thyroid drugs, especially methimazole and carbimazole, and colchicine. These are 3 drugs very, very important for exams. Apart from that, one important thing that for Western standard exams which is very important is the cocaine. But cocaine alone will not produce agranulocytosis, but if it's adulterated with another drug called levimazole. If it's adulterated, because to increase the effect of cocaine, they will adulterate with another drug called, it's an adulterant actually, it's not a true cocaine, it's adulterated with levimazole. This combination can result in neutropenia. But cocaine alone cannot produce neutropenia because this levimazole is the one that induces antibody against neutrophils. And this levimazole induced neutropenia, along with cocaine, is having high risk if the patient is HLA-B27 positive. Whenever, the same HLA-B27 that we are going to see in ankylosing spondylitis and seronegative spondyloarthropathies, that is the one that is going to result in that is the same HLA-B27 is going to increase the risk of neutropenia, that is antibody formation against this levimazole cocaine complex in patients who are taking this. So HLA-B27 increases the risk. And finally, lot of neoplasms. Neoplasm that can produce neutropenia is MDS, myelodysplastic syndrome, leukemia. In leukemia, the blasts are increased, not the neutrophils. There are a lot of difference between the premature and immature, and the blastic cells increasing and the mature neutrophils increasing. Mature neutrophils only can fight the infections, not the blasts. Even though a lot of WBCs that are there in leukemia, patient will be absolutely immunosuppressed, and a lot of infections they are predisposed because blasts cannot fight the infection. Even though they are increased to 1 lakh, 2 lakh, that doesn't matter. Then leukemias, and a lot of leukemias are there. Hairy cell leukemia, LGL, large granular lymphocytic leukemia syndrome, so many things. Anything can cause neoplasms, can result in neutropenia. So these are some of the important things that you have to note about the neutrophils. I told you about the basics, the functions, as well as the conditions that produce neutrophilia as well as neutropenia. So apart from this, other cells are not that important for exams, but still let us see some few basics. You know what is this cell? This cell is nothing but a eosinophil. The moment you talk about eosinophil, let us see about the basics of eosinophil. Basics of eosinophil. Typically the DC count of eosinophil is approximately 1 to 4%. Then they have acidophilic granules in the cytoplasm. That's what is very important. A lot of granules in other cells are actually basophilic, but eosinophils have acidophilic. That is why they are called eosinophils. They stay in eosin because they are acidophilic granules. So you can see this acidophilic granules in the cytoplasm, and the nucleus is typically in the spectacle shape. Spectacle shaped nucleus or a bilobe nucleus, typical of a eosinophil. And presence of acidophilic granules is what is the characteristic feature of an eosinophil. And diameter, again the same diameter as that of neutrophil, that is 12 micrometer. And what is the one that's going to attract the eosinophil is the histamine. Histamine is the one that pulls the eosinophil to the areas where histamine is released. Very important. And next thing, if you want to ask the function of eosinophil, generally eosinophils have very poor phagocytic abilities, which means they are very poor phagocytic agents. So they don't generally are important for phagocytosis. Neutrophils take over that part, but they are very important in generating immune response against the parasites, because they are going to release IgE, major basic protein, eosinophilic cationic protein, lot of areas to a lot of this kind of cytotoxic molecules in the areas where parasites are there. So that is the reason they are very important for immunity against the parasitic agents. At the same time, they are also very important for mounting allergic responses, and they are the ones that are implicated in certain allergic reactions like bronchial asthma, atopy and all these things. But anyway, so these are some of the basic functions. Parasitic immunity, that's what the key for understanding eosinophils. But they don't have big phagocytic abilities. And when you call a eosinophilia, when the counts are high, when you are going to call eosinophilia, whenever the absolute eosinophil count is going to be more than 500 per microliter. So this is what we are going to call it as eosinophilia. Whenever it is mild eosinophilia, you can call it as 500 to 1000 range. Whenever you want to call moderate eosinophilia, it's in the 1000 to 1500 range. Whenever the counts are more than 1500, I'm going to call it as severe eosinophilia. Or remember, this is not important if it is more than 10% of the differential, 10% the differential count, but this is not at all important. What is more important is the absolute eosinophil count only. So this is what the definition of eosinophilia is. So whenever they ask you about eosinophilia, the first one most important is the parasitic infection. When you take the books and see, that's what they would have given. The first one is the parasitic infection. That is where the first thing you have to understand about the eosinophilia. Second one, in a lot of allergic reactions, as I told you, like asthma, hay fever, atopy, then eczema, allergic bronchopulmonary aspergillosis, so many areas you can have high eosinophils, any allergic reaction. Then third, in certain connective tissue disorders or collagen vascular diseases, like you have in rheumatoid arthritis, Churg-Strauss syndrome, polyarteritis nodosa, eosinophilic fasciitis, and all these things. So most important in this is the Churg-Strauss syndrome. That is the exam question, where you have profound eosinophilia. Apart from the eosinophilic fasciitis, rheumatoid arthritis, PAN and all is not exam questions. Then you have endocrine. Endocrine causes, very important is adrenal insufficiency. Very, very, very important, which is discussed in detail in endocrine section. Adrenal insufficiency typically produces eosinophilia. Similarly, Cushing's will produce eosinopenia, I'll tell you. So, but here adrenal insufficiency and Addison disease typically produce eosinophilia with neutropenia. Very, very important. Adrenal insufficiency, eosinophilia with neutropenia. Then you have a lot of neoplasms that can produce, for example, Hodgkin disease, CML itself, mycosis fungoides and Sézary syndrome. Then mastocytosis, a lot of entities are associated with eosinophilia. Then very important is the atheroembolic disease. Atheroembolic disease is usually happens after catheterization, intravascular catheterization, where the atherosclerotic plaque is disrupted and they go and dislodge in multiple areas, causing infections. End organ related vessels, small vessels will be blocked by this disrupted plaques of atherosclerotic granules, and that might result in ischemia to the end organs and infarcts, small microinfarcts causing organ dysfunction. That's what we call atherembolic disease, which is discussed in detail in the kidney section again. So that atherembolic disease can have eosinophilia, to be honest. So this is also referred to as something called cholesterol emboli syndrome. And finally, you have something called hypereosinophilic syndrome, which is very important to understand. Hypereosinophilic syndrome. What do you mean by hypereosinophilic syndrome? Number one, first thing very important to understand is associated with a very important gene mutation called FIP1L1 PDGF receptor A. This is called PDGF receptor A fusion. So FIP1L1 PDGF receptor A fusion. PDGFA receptor fusion, very, very important, multiple times asked question. This FIP1L1 and PDGF receptor A fusion is one of the very important things that regularly asked in hypereosinophilic syndrome. And next thing, what you will see is the patients will have absolute eosinophil count of more than 1500 for at least 6 months plus no identifiable cause. So which means if you have identifiable cause like parasites, like hookworm infection or ascariasis or any other identifiable cause like Churg-Strauss syndrome, it will not come under hypereosinophilic syndrome. There should be no identifiable cause, which means it could be without any reason, idiopathic. Usually this, for high degree, this severe eosinophilia will result in tissue damage with multi-organ involvement. They will cause tissue damage and multi-organ involvement. Typically, multi-organ involvement is they will involve the valves, they will involve the central nervous system, they can involve the skin, and they can cause infiltrations in the lung and they can affect the lungs also. At the same time, there will be no clonal markers. No clonal markers will be established. This is very, very important again, because if you are able to identify a clonal marker that goes towards eosinophilic leukemia, that is different. That is a malignancy. As simple as that. This is not a malignancy. Hypereosinophilic syndrome is just an idiopathic elevation of number of eosinophils in the blood that is going to cause organ damage. That's a disease. That's all. It's not a leukemia. So if you are going to identify a clonal marker, that's a malignancy. This hypereosinophilic syndrome is not a malignancy. Very, very important point once again. So that's why it's very important to understand this hypereosinophilic syndrome. Please do understand this FIP1L1 PDGF receptor A mutation. At the same time, there are two classic points that you have to know, that there is no clonal marker that rules out malignancy. It's not an eosinophilic leukemia, it is just hypereosinophilic syndrome. And second thing, they're going to have a persistent elevation of eosinophils that was severe level, severe eosinophilia with no identifiable cause. At the same time, they will have multi-organ involvement and tissue damage. So this is what is the idea of understanding hypereosinophilic state. Whenever eosinophils are decreased, we are going to call it as eosinopenia. So as per the understanding, the first thing you have to tell about eosinopenia is in Cushing's. I told you, Addison's and adrenal insufficiency, neutropenia and eosinophilia. Similarly, in Cushing syndrome, you are going to get neutrophilia and eosinopenia, as simple as that. And second thing, typhoid, very important for exam sake, but not really important for practice, but eosinopenia, exams. And you can get in certain sepsis, not that important. So Cushing's is the most important that produces eosinopenia. So with this, we are finishing the eosinophils also. Then we are moving on to the next cells. These are nothing but the basophils. Basophils. As usual, basophils doesn't have much to understand. So if you want to know about the basics of the basophil, they contribute only to 1%, which means it's the least among all the WBCs, basophils. Diameter is typically around approximately 10 micrometer, and they have typical intensively staining basophilic granules. Even the nucleus will be obscured by this basophil. You can see, you cannot even see the nucleus. The granules completely, obscure even the nucleus. So have very intense basophilic granules, little smaller in size. So this is what characteristic feature of a basophil. They have Ig receptors on the surface. and they only circulate for minutes in the blood. Only they spend minutes in the circulation. After this minutes in circulation, they are going to migrate into tissues. So these are some of the important things about basophils. And this basophilic granules, the most important components of this basophilic granules, if they ask you, answer must be histamine and heparin. Often the granules will completely obscure the nucleus, catalytic feature of which is very difficult to identify basophil in the peripheral smear, not easy at all. If you see it, you are lucky really. So functions of basophils, typically they produce leukotrienes, they produce, again important for allergic reactions, they produce heparin and histamine, again very important, and finally they produce a lot of IL-4. Remember, basophils are considered to be storehouses of IL-4 and IL-5. They produce lots and lots and lots of IL-4 and IL-5. They are considered to be storehouses of IL-4 and IL-5 because this is very important for differentiation into T helper 2 pathway, of the T cells to differentiate into T helper 2 pathway. I'll tell you one, when we are going to discuss on the adaptive immunity, I'm going to discuss in great detail about this IL-4, IL-5 and the Th2 pathway, Th1 pathway and all these things. So right now it's okay, just understand this IL-4 and IL-5 is very important for differentiation into Th2 pathway. Allergic reaction, because IL-4 is very important for Ig production and class switching to Ig molecules, and IL-5 is very important for eosinophilic activation and eosinophilic movement into the area of interest. So that's why these are very important for Th2. Th2 is the allergic pathway, T helper 2 pathway. All these are very important, and they don't have literally no phagocytic abilities. Like eosinophils, they are not phagocytic, so they don't have any phagocytic abilities. So these are some of the important properties of basophils. If you ask about basophilia, so increased thing is what we refer to as something called basophilia. So whenever you ask about basophilia, the definition, whenever the number of basophils, absolute basophil count exceeds more than 150 in the the blood, that's what we call basophilia. The first thing you have to think about basophilia is myeloproliferative neoplasm. For exams, in that too, a lot of polycythemia vera, essential thrombocythemia, progressive primary myelofibrosis, CML, all these things is going to come under myeloproliferative neoplasms. But the most important thing for exams you have to understand is CML. That's all. Very, very important. Literally any myeloproliferative neoplasm can produce basophilia, but CML is the most important because lot of even definitions of accelerated phase blast crisis, everything is dependent on the basophil levels also. So basophil is very important for CML more than anything else, basophilia. And you can see in Hodgkin lymphoma, you can see in hemolytic anemias. These are not important, but still just for completion's sake I'm telling hemolytic anemias and asplenias, especially after splenectomy. In allergic diseases, during allergy you might have a eosinophilia, along with that you might have a little basophilia also, which means any condition that produces eosinophilia can also produce basophilia. So but that's not important, but the most important, if you want to know, answer is CML. That's it. That is what the very, very important thing about basophilia. Reduced is what we call it as basopenia, but in general I am not going to talk about any cause of basopenia. Anything that produces bone marrow suppression can produce basopenia, but very difficult to assess because normal looking on a single basophil itself is very difficult. Then how can you assess on a basopenia? Not possible. So that's why it is very difficult to assess. I am not going to tell any causes. So this is all about the basophils. Then if you see this cell in the peripheral smear is what we refer to as the monocyte. Typically, if you ask about the basics of the monocyte, so the first thing, DC count, it contributes around 3 to 7%. Diameter is around 5 to 20 micrometers. It might be smaller or even it might be bigger also. And in the circulation, once the monocyte released in the circulation, it remains in the circulation for approximately 8 hours. Then it migrates to tissues. After this 8-hour mark, they migrates to tissues where obviously, as I told you, they are going to be called as something called macrophages. This tissue macrophages in different areas you call different thing because these tissue macrophages form an important system called reticuloendothelial system, RES. They are called by different names in different areas. For example, in skin and connective tissue, they are called as histiocytes. In brain, they are called as microglia. In brain, they will be called as microglia. In liver, they will be called as Kupffer cells. All these things are extreme basics. That's why I told you the topic itself is basics of WBCs. Then in lymphatic channels, they will be called as littoral cells. In the lungs, they will be called as pulmonary alveolar macrophages. In the bone, they form the osteoclasts, and in the kidneys, they form something called intraglomerular mesangial cells, mesangium. Intraglomerular mesangial, simply you can call it as mesangial cells or mesangium. Then in placenta, they will be referred to as something called Hofbauer cells. Sorry for the spelling, I don't know whether it's right or wrong, but it's Hofbauer cells. And you have splenic and bone marrow macrophages also. Splenic, bone marrow, and even lymph node macrophages are there, which is not given any specific name. So these are the things that have specific name for the reticuloendothelial system, but apart from that, this is the monocyte macrophage system. And function wise, if you ask me, it is the one that has innate immune functions. At the same time, I told you they are going to connect with the adaptive immune system because they serve as something called antigen presenting cells to the adaptive immune system. How they are going to present is through, they have MHC class 1 and MHC class 2. They are going to present the antigen through MHC class 1 as well as MHC class 2 molecules, which we'll discuss in detail again later on. So they are the ones that are called as professional. These are some examples of professional antigen presenting cells. There are a lot of non-professional APCs, but dendritic cells and macrophages are professional APCs, which their function is the antigen presentation only. So innate immune function, predominantly they have something called phagocytosis. That is a very important innate immune function of macrophages, but they also form a bridge between adaptive and innate immunity by virtue of its function called antigen presentation. That's all. So this is the major function of the neutrophils. Apart from that, monocytes. Apart from this, whenever the counts are increased, we are going to call it as monocytosis. When you are going to call monocytosis, whenever the counts are more than 500 per microliter. Remember, more than 7,500 is neutrophilia, more than 150 is basophilia, more than 500 is eosinophilia, and more than 500 is monocytosis. So if you ask me what are the causes of monocytosis, typically it can happen in certain infections, but very important infection, one of the times they asked in AIIMS exam, that is tuberculosis. TB can produce monocytosis. Then you can get in SLE, you can get in some atypical infections like listeria, you can get in other atypical infections like rickettsia, brucellosis. In all these things you might get monocytosis. Apart from that, you might also get in fungi, parasites like malaria and protozoal infections. A lot of areas you can get monocytosis, but this TB alone has been asked in one AIIMS exam, I think probably in 2012, and parasites especially they asked in malaria also. In one of the microbiology questions, probably in All India 2010, I guess. But anyway, so malaria they asked and TB they asked. But apart from that, I don't know about the other things. But these are the important areas where you can see monocytosis. And a lot of inflammatory conditions. Inflammatory conditions like IBD, sarcoidosis. These are the areas where you can see in collagen vascular diseases. Collagen vascular disease you can get monocytosis, and similarly neoplasms can produce monocytosis, like you can get in Hodgkin lymphoma, leukemias, then you can get in myeloproliferative neoplasms, and a lot of carcinomas you can get monocytosis, but where the money is in your TB and malaria, that's it, because that's a previous year question, that's it. So then you can get in monocytopenia. And monocytopenia can be seen in sepsis, especially when you have a gram-negative endotoxic shock. You might get sepsis. At the same time, chemotherapy drugs. Chemotherapy can result in monocytopenia, but that's not important. So the function is what is very important, and this probably, now we are in the era of applied exams rather than applied questions, rather than this kind of one-liners nowadays. I don't think they're going to ask you anyways, but still, since they are being asked in the past, I've been just mentioning all these things to you. Apart from that, I don't think these are really going to be important. So these are the things that are important about the monocytes. You can see the monocytes doesn't have that much granulations, to be honest. They have very little granules. Usually they have a more of a clear cytoplasm. That is the main difference between the granulocytes and the monocytes. They don't have that much granules. They have maybe a very, very fine granules, or they don't have granules at all. Usually, in the sense, they have a very, very clear cytoplasm. And nucleus is typically, it is peanut shaped, isn't it? The nucleus is typically donut or a peanut shape, something very different. It's not like what you see in the other cells. And final nail in the coffin, we're going to discuss on the mast cells. This is very difficult to identify. This is from the tissues. This is what we refer to as something called mast cells. Typically, if you want to know the basics of the mast cells, first of all, they are not found in blood. Not found in blood at all. They are seen in the tissue, in the submucosal areas typically. That's where you see the mast cells, especially in the areas of allergy. And they are extremely similar to basophils, which means they are very rich. You can see a lot of basophilic granules. They even obscure the nucleus itself. So they are very, similar to basophils, but they are seen in the tissues. That's all. And they have c-KIT receptors on the surface. This is very, very important, because I told you basophils express different, different receptors on the surface. They express Ig receptors on the surface, but whereas these mast cells will express this c-KIT receptors on the surface. Very, very important. c-KIT receptors on the surface. I'll tell you why. Because it results in one condition called mastocytosis. We'll discuss in some time. And what are the functions? If you ask me the functions of the mast cells, they have Fc receptors typically for the Ig. They have Fc receptors for the Ig, which means whenever you have a mast cell, they have receptors. These are called as Fc receptors, and they are going to sense the Fc portion of the Ig. That's the epsilon chain. That's what going to sense. Whenever an Ig molecule binds with the Fc receptor of the mast cell, they are going to degranulate. That's all. They are going to degranulate. So this is what we refer to as something called a type 1 hypersensitivity, and mast cells are very, very important for eliciting a type 1 hypersensitivity reaction, because they have that receptor for Fc portion of the immunoglobulin E molecule. And they can be stimulated either by basophils as well as eosinophils. Both basophils as well as eosinophils can stimulate the mast cells. Again, they might also cause the mast cells to degranulate. And you can have mast cell degranulation due to, even non-immunological substances can also cause degranulation of mast cell. We call it as anaphylactoid reactions. But again, I don't know where to discuss all those things, but maybe in the subsequent sections in between the videos itself, we'll discuss more about what is an anaphylactic reaction, what do you mean by anaphylactoid reaction. A non-immunological degranulation of mast cell is what we called as anaphylactoid reaction. Ig mediated immunological degranulation of mast cell is what we refer to as anaphylactic reaction probably. So this is what is very important. So which means mast cells can degranulate immunologically as well as non-immunologically as well. So very important thing, only one thing that you have to know: whenever the mast cell levels are increased, that is what in the body, not in the blood, because they're not seen in the blood typically. This is what we refer to as something called mastocytosis. Remember, very important, the levels of the mast cells are increased not in the peripheral smear, because mast cells you won't see in the blood. This increased amount of mast cells you are going to see in the tissues. Very typically in the skin, in the bone marrow, and in the organs. For example, liver, spleen and all these areas. So this is where you are going to have increased number of mast cells. For example, If they ask you most common site where mast cells are increased in mastocytosis, answer is skin. Similarly, if they ask you most common extracutaneous site, most common extracutaneous site for mast cell accumulation in mastocytosis, systemic mastocytosis, answer is bone marrow. Very important. Remember, mast cells in the skin, if it is increased, they will lead to severe urticaria. Severe urticaria and pruritus. They can even cause something called dermatographism. Dermatographism, like you just Google it and you find it. What is dermatographism? Just you write dermatographism with a small sharp thing, and exactly the same thing will be seen very clearly in the skin. Whatever you write, like that typical, like it's an exaggerated mast cell degranulation in the local area in response to trauma, because mast cells can degranulate not only immunologically, non-immunologically also. One of the important non-immunological reasons why the mast cells degranulate is trauma. Again, that's the reason why you get this wheel-like reaction when you produce a trauma. That because of mast cell degranulation, they degranulate in response to trauma as well. So this is what we refer to as because of excessive mast cells, they produce severe urticaria, pruritus, and dermatographism in the skin. They can even result in urticaria pigmentosa as well, and they can accumulate in the bone marrow, causing bone marrow suppression also. Result in neutropenia and all other thrombocytopenia. All these things are also possible, and other organ dysfunctions are also possible because they accumulate in the other areas as well. So, what is the reason? Pathophysiology. This is where your question exam is. It is due to c-KIT mutations. That is due to c-KIT mutations. That's why I told you they express this c-KIT receptor on the surface. That is due to c-KIT mutations. This, if they ask you the mutation that is responsible for systemic mastocytosis, answer is c-KIT mutation. This is typically called as D816V mutation. I know in and about all these mutations because it's the bread and butter for me. But anyway, so D816V, very important, especially for hematology exams, if you're writing specifically for hematology. But apart from that, if you just know it's c-KIT mutation in systemic mastocytosis, that's more than enough. For hypereosinophilic syndrome, I told you one mutation that's called FIPL1 and PDGF receptor A mutation. But similarly in systemic mastocytosis, it is your c-KIT D816V mutation. So that's what is going to happen. So how you are going to make a diagnosis? Whenever a patient is coming with uncontrolled urticaria, organ involvement with probable bone marrow suppression, you are going to do diagnosis by certain investigations called mast cell tryptase will be increased, and you can do a skin biopsy which is going to show excessive mast cells in the skin, and these mast cells will be CD117, that is c-KIT positive, very important. But remember, is this really specific? Answer is no. This is non-specific. Why? Because in skin biopsy, having excessive mast cells can be seen in any allergic reaction, like any type 1 hypersensitivity reaction, even an atopy, allergic urticaria also you can see. But this is not going to be specific. But what is going to be specific is going to do an organ biopsy. Organ biopsy typically from the bone marrow, or you can do a liver biopsy, where if in this area, if you prove excessive mast cells that are located, that is showing this c-KIT positivity, then you can call this is specific for systemic mastocytosis, not when the mast cells are present in the skin. But anyway, there will be excessive mast cells in the skin, but that is not specific. That's what I mean. Organ, bone marrow or liver, if you have excessive mast cells, then you can call it as specific for mastocytosis. Treatment wise, you have to give a c-KIT and this FLT3 ligand inhibitor. So because c-KIT's important ligand is the c-KIT is what SCF, stem cell factor also. So c-KIT FLT3 ligand inhibitor. So that's what you have to give. One of the important drugs is what we call as midostaurin. Remember, imatinib is not effective. I'll tell you where imatinib will be effective in subsequent sections, especially in CML, and related mutations are also there. Certain tyrosine kinase domains where your imatinib will be useful, but here imatinib will not be useful, especially in the c-KIT FLT3 ligand mutation. So this is c-KIT FLT3 ligand inhibitor is what you should use. One of the important c-KIT FLT3 ligand inhibitor that is used in systemic mastocytosis is something called midostaurin. In this type, type of CD170, in this type of c-KIT mutation, imatinib is not effective, because you'll be asking, sir, certain c-KIT mutation imatinib is effective, but here in this particular D816V mutation, imatinib will not be effective. Only in certain mutations imatinib will be effective. So these are the things that you have to know about the systemic mast cells. I mean, low mast cells, I don't know if you find any cause, you can tell me, but apart from that, the systemic mastocytosis is a very, very important exam question, especially this mutation and the drug that is used, midostaurin. And very important point, in this type of c-KIT mutation, D816V, imatinib is not at all effective. Very important point to understand. So I think with this we are concluding the basics of the WBC video. In this particular section, I hope this is clear. And in the next section, probably we might be discussing on the neutrophilic disorders and the lot of diseases that are related to rare neutrophilic disorders, I mean, which are still important for exam. So let's move on.